Hello, everyone. It is a pleasure to welcome you to the first edition of this series of six lecturers entitled Infectious Disease Outbreak, Social Sciences at the Heart of Surveillance, Prevention and Intervention Strategies. This series of lecturers is led by the University of Ottawa in collaboration with several universities in Canada, Africa, and elsewhere, including Western University, York University, University of Hong Kong, University of Kinshasa, and others. The four projects that are part of this collaboration have been funded by IDRC, SHRC, and CIHR. We are pleased to have with us different researchers from different countries to address the issue of the day, COVID-19 in low and middle income countries, the expected disaster that did not happen. It is clear that some low and middle income countries have been hit hard by the pandemic. However, some countries with very weak health systems have been able to cope and resist. Today, we will discuss this issue with three special guests. But before introducing them, let me welcome Dr. John Silverst, Vice Dean of Research in the Faculty of Social Sciences at University of Ottawa, in his special welcome remarks. Dr. John Silverst.
Yes, dear colleagues, hopefully you can hear me. On behalf of the Faculty of Social Sciences, I'm pleased to welcome you to this event, part of a series on infectious disease outbreaks, social sciences at the heart of surveillance, prevention, and intervention strategies, today with a particular focus on COVID-19. Though I'm sorry that we could not welcome you to our campus for this event, I'm pleased that so many of you could join us today virtually. First, a few words about our faculty, which you can imagine I'm enormously proud. The Faculty of Social Sciences is the largest faculty at the University of Ottawa, boasting over 250 researchers, including 9 academic units and a wide range of research chairs, research centers, and research institutes. The research that's conducted in our faculty stretches all the way from the level of neurons to international security concerns. But what unites us is the firm belief that social sciences theory and research plays an invaluable role in the health and well-being of individuals, communities, our nation, as well as our global community. The challenge we face is ensuring that our work is shared widely and critically in ways that can inform understanding our debates and our collective action. The discussion you're going to have today touches on a number of important themes for our faculty, including health, security, and collective action. I wish to congratulate my colleague, Dr. Sena, his partners, and his team for organizing this event today. And again, on behalf of the faculty, thank you to each of you for joining us, and I wish you an engaging and enlightening morning. Thank you.
Thank you, Dr. Silverst. I want now to welcome Dr. Dominique Chao, who is the Vice President Programs and Partnerships at IDRC. She's the person who initiated this rapid fund during the 9th Ebola virus disease outbreak in the Democratic Republic of the Congo. Thank you, Dr. Chao, for joining us. You got the ball.
There we go. Very nice to be here. Merci beaucoup, Jude. Je vais parler en anglais. Mais ça me fait vraiment plaisir d'être parmi vous aujourd'hui. And it's my pleasure too, as mentioned just now, to be here to launch this virtual colloquium series, and congratulations to the university for hosting this. And I'm really particularly pleased, as Jude has mentioned, to set the stage for this conversation amongst the Canadian and African colleagues gathered here today who worked toward informing that response to that Ebola outbreak in the Democratic Republic of the Congo, initially in 2018. It really couldn't be more timely to draw on the experiences of this research as we work to contain this most devastating pandemic in a century. Now, for those of you who don't know IDRC, For 50 years, we have worked as part of Canada's international assistance efforts to support research in developing regions, led by researchers in those countries to address development challenges such as this in those regions, as well as globally. And we do this as we work towards building toward our vision of a more inclusive and sustainable world. Our programs cover health, agriculture, environment, climate, economies, governance, and science and technology. Now, in our work at IDRC, partnership is key to achieving impact. And the research you will hear about today is a beautiful example of the value of partnership, partnership for innovation. Partnership is key also for amplifying and increasing the reach of knowledge. And it's also key to building networks that can be leveraged and mobilized again in the future, for example, when we're faced with a situation like the pandemic of COVID-19. This is also, as you had mentioned, a partnership between funders, between ourselves at IDRC and the Canadian Research Councils, the Canadian Institutes for Health Research, and the Social Sciences and Humanities Research Council. And this is a unique feature of the Canadian research funding ecosystem, in that we have an organization like IDRC focused on research, funding research in developing regions, and this collaboration with the funding councils who are focused on funding Canadian researchers. Building on past collaborations between IDRC and the research councils, some of them in response to earlier public health emergencies, we came together to rapidly mobilize this funding for Canada-Africa research teams in response to the outbreak of Ebola virus in DRC back in 2018. As you know, at that time in early 2018, this new large outbreak of Ebola virus was getting underway in the Equata province, and it was moving into urban areas. And we were all, I think, in the global health community, quite worried that this would lead to another massive outbreak like what had just happened in West Africa a few years earlier. And although we did not know it at the time when we were bringing together this research fund, DRC was about to suffer a second, much larger outbreak of Ebola virus in the north of the country. And this one would become the world's second largest outbreak that only was declared over in June of this year. 3,400 people died, nearly 3,000 people died of the more than 3,400 people who were infected. So this was although we did not anticipate that necessarily when we were coming together to mobilize the expertise, we were worried about what was to come. And because this second outbreak took place in an active conflict zone, well, we know now how much more difficult the situation would become. And DRC is no stranger to the Ebola outbreaks and has a great deal of expertise and capacity, some of which we will hear from today. And they were armed with this new vaccine as well that had been developed, in fact, in Canada, and tested in West Africa and proven to be safe and effective, with some Canadian funding, including ours in that work. But the response, despite these tools, was really hampered by that insecurity context, by lack of trust by the communities in public health, in government, fears and concerns around vaccination, unsafe traditional cultural practices around treatment of people who were ill and treatment of people who had died. Misinformation was circulating. And a lot of movements of people through the region, which made this just a very complex situation. Now, this is not a unique situation. It was a unique situation, but it's not the only place where these factors come into play. And we are realizing this even in response to COVID, how misinformation, how lack of trust in public health, lack of trust in government, traditional cultural practices, movements of people all contribute to make it very difficult to contain epidemics. Now, when we were thinking of this new fund, we were drawing on lessons from the West African Ebola epidemic, where it had been very clear that lack of knowledge and attention to the social cultural beliefs and practices and the broader social, gender, inequality, economic and political contexts in those West African communities was allowing the virus to spread more in the initial phases of the epidemic and hampered the epidemic response as well as the rollout of those clinical trials of life-saving vaccines and treatments. So learning from this, we recognized with CIHR and the Social Sciences and Humanities Research Council a gap. There is a need for this interdisciplinary research, and that Canada could offer quite a lot of that expertise, but that there was also so much expertise in Africa that was growing in the aftermath of what had happened in West Africa. And there is this expertise in DRC itself, which is a champion de la lutte contre Ebola. So mobilizing that expertise, we pulled together this rapid research fund. Not a huge amount of funding, but we think a catalytic amount of funding that led to these 4 innovative projects that you will be hearing about today that responds to and hopes to improve the response to outbreaks. And they began their work just as DRC was beginning what was to become this massive response to the outbreak in North Kivu, with the support of the international community, 16,000 healthcare workers, over 300,000 people vaccinated with this famous vaccine. But as we are learning from COVID-19, the need for a broader framing of epidemic research and response is only growing. This is we talk about, and the research community is very focused on life-saving medical countermeasures, treatments, vaccines, diagnostic tests, personal protective equipment. Great, important, crucial. However, insufficient, because epidemics are prevented and controlled by people working with the best technology available, in collaboration with communities who are able to bring about changes in people's behavior. It's about people. And the more we know and learn, the better about how people think, how people behave, how to bring about changes in behavior, how to bring about collaboration, how to bring about understanding, the better we will become at preventing and containing the inevitable next epidemics. As a funder of research in developing regions focused on big challenges of things like climate change and inequality and reaching the Sustainable Development Goals, we are seeing how devastating epidemic disease can be. And the epidemic of COVID-19 is setting us back several years in terms of progress towards these great global goals. So in the context, as we launch a new 10-year strategy, of course, we are committed to continuing this work. We cannot not continue to focus on mobilizing interdisciplinary research to help strengthen capacities and innovative responses to help prevent and contain infectious diseases. I congratulate all of you researchers on this groundbreaking work. And of course, we hear that you are having considerable impact, not only to contain that outbreak in North Kivu, but also to deal with yet another outbreak of Ebola in Equateur province this year, and to inform governments not only in DRC, but in other countries in Africa in the response to COVID. This was groundbreaking and prescient work. I'm very happy to be here to listen to this discussion this morning. Thank you for your attention. I hand it over to the experts. Place aux chercheurs. Merci.
Thank you, Dr. Sharon. Merci beaucoup, Dr. Sharon. Before moving on the conferences themselves, we'll have a quick presentation of each project. First, we'll have Dr. Karine Grépin from the University of Hong Kong. She will be followed by Dr. Aris Ali from York University, and Dr. Elise Nouvet from Western University. Dr. Agrippa.
Hi, everyone. So it's wonderful to be here. I'm just waiting for my slides to pop up. Those aren't them.
Can go now.
Anyways, as others have mentioned, I was involved with one of the projects that was funded by IDRC back in 2018, which in many ways feels like a complete lifetime ago. Sorry, I don't see my slides. Can those be brought up?
So people see your slide.
Oh, people see them. I just can't see them.
You
So
don't see them?
okay.
Normally, you have to see them. I don't know.
Okay, so I can't see them. You can't see my slides. Okay, or you can or can't?
Let me check.
Okay.
Saba, you can see the slides?
I can see just the front page of the slide.
You see the slides. Okay, so I just can't see them. So I'm going to switch my window. I was assuming I would see my own slides, but I can't. Anyways, our project was looking at the role of routine health information and how data that comes through administrative sources could be used to inform the response to Ebola in the DRC. Next slide. This is a joint research project. At the time when this was launched, I was based at Wilfrid Laurier University in Waterloo. I'm now at the University of Hong Kong. So again, in this kind of other lifetime, it feels like. But this is in collaboration with Dr. Serge Mayaka, who's based at the Kinshasa School of Public Health in the DRC, as well as some co-investigators both in Canada and the United States, as well as a data science group that's based in Belgium. Next slide, please. So this project was really motivated by work that I had been involved with in West Africa during the Ebola outbreak there. It was when the outbreak happened, one of the things that became very obvious was that there were very dramatic declines in the use of health services, not just people who are necessarily being affected by Ebola directly, but rather because of factors like fear, which might be preventing, can you go back up slides, please? Preventing people from seeking health services, that's great. As well as supply side factors like the fact that a lot of health workers were feeling unsafe at work and weren't coming to work and so on. And it's possible that some of the health effects of that were actually larger or at least at the same magnitude as what we were experiencing through Ebola. And so there was some pretty significant public health concerns about what happens when people stop going to clinics. The second thing that we learned during West Africa was that it was very, very difficult, and even today, very difficult to go back and understand what actually happened within health systems in West Africa, because the data that we typically rely upon to answer those questions were not available in an outbreak situation. And so based on that, that led us to the DRC, where actually a bunch of us had actually started to collaborate already around questions about understanding real-time changes in health service utilization using administrative data there. And then when Ebola struck, it became a sort of perfect situation to sort of investigate whether or not there were changes in health service utilization happening in the context of Ebola. When this project started, we thought we would be looking at the Equateur outbreak predominantly. And then of course there was the North Kivu outbreak, and then the second outbreak of Ebola in Equateur. So we've been sort of shifting our research questions around to look at these different outbreaks of Ebola. And then of course we have COVID that's happened this year. And so we've also been asked to support, to answer the same kinds of questions in the context of COVID and what's been happening there. So next slide, please. So I don't want to spoil the surprise, but in the next session, which will be in early December, my co-authors will likely be here presenting some of these actual work. But the basic question overall that we had with all of these different outbreaks was, how did these infectious disease outbreaks affect the utilization of health services? One of the things that was quite interesting and innovative that happened in the DRC, based on learnings from previous outbreaks, was that it was very important to reduce financial barriers to people using health services in outbreaks. And so when Ebola happened, they actually made health services free. And what you can see looking from the results from our study, that there was actually quite a sizable increase in use of health services in Equateur during an Ebola outbreak. So very different to what we found in West Africa. And when that free care policy went away, the increases in these services went away. Next slide, please. As I said, we've been able to shift our studies to look at these different outbreaks. So again, we looked at this again in the Eastern DRC, and again, they introduced a free care policy. And again, we were able to see that there were these significant increases in use of health services in a month-to-month kind of scenario based on the availability of this free care policy. And contrary to what we were seeing in West Africa, we weren't seeing major declines in use of health services amongst the general population, even when those free care policies were not in place. Next slide. As I mentioned, we have also begun, as of March of this year, also helping to inform what's happening in the DRC right now in the context of COVID. And I think this fits very much in line with sort of the broader theme of this conference, which is, was it really a disaster? At the beginning of the outbreak, the pandemic, I should say, there was a huge concern that there would be major declines in use of health services, the so-called secondary health effects or collateral damage of COVID on priority diseases. We have been able to identify a significant decline in use of health services, probably on the order of about 10%. But it hasn't been evenly shared across the country. And in fact, where we've seen the most pronounced effects is mostly in Kinshasa, where there was a lockdown of the population in one neighborhood. And there we saw very sizable declines in use of health services. Next slide, please. So just in terms of what we've managed to accomplish, I think there's a lot of important lessons that have come out of this. So one, I think it's been very clear that even in contexts like the DRC, and these so-called kind of weak health systems, we can track in real time what's happening within the health system using administrative data. And then this platform is quite flexible. As you can see, we've been able to shift from outbreak to outbreak and now to the pandemic, and in real time been able to answer these questions. We've also learned some important lessons about data flows and data sharings and how those systems can be improved. And as I said, we've been working also a lot in this project in terms of supporting actors in the DRC right now who are responding to COVID in real time and helping them to understand what's happening there. And there's even been a request to sort of integrate the analysis we've been doing into their sort of COVID dashboards so that they would be able to do this themselves in real time. Last slide. So I'm just going to stop there. I don't want to spoil, as I said, the big discussion about this on the next session, which is on use of health services. But if anyone has any questions, please send me a note.
Now, Dr. Aisali.
Yes, thank you, Jude, and thank you also for organizing. I'll just go over briefly to give you a flavor of our research. So the project is called The Role of Social, Cultural, and Environmental Factors in Improving the Ebola Virus Disease Response and Resilience, and with a particular focus on what are called community-based initiatives. And this research is done in a team with myself and Dr. Masoka Fala, who led the response in Montserrat County, where Monrovia is, and Dr. Joseph McCarthy, who from Sierra Leone, from Freetown, who is also on the panel. So I look forward to his talk as well. Sabah, next slide, please. So this research project had two main objectives. The first one was to identify and analyze the social aspects, because I'm a sociologist and I tried my best to make Joseph and Masoka sociologists as well, because as you know, an epidemiological response is really about people. So the term social we use to include the cultural, political, and economic dimensions, okay, as well as the environmental dimensions of the outbreaks in West Africa and in the DRC. And the idea was to use the insights gained from the sociological and political economic analysis of what happened in West Africa to see how it could be applied in the DRC. Again, with the emphasis on community-based initiatives, which is about the interaction between lay people in the informal settlements and in the villages with technical experts, okay, a sort of citizen science, so to speak. This is the basis of community-based initiatives. And they were found to be very effective in the West Africa outbreak response. So how could we sort of transport this over to the DRC? That was the practical question for us. Saba, next slide, please. So this was qualitative research, focus groups, and key informant interviews. Then we had 2 training workshop sessions in the Congo as well to sort of transmit the knowledge, to talk about best practices from the West Africa outbreak and see how it could be applied in North Kivu, Butembo, Beni, and so on. Turi. Saba, next slide. So, as I said, these are just some pictures of our research activities. On the left, top left, this is interviews that were conducted in West Point in Monrovia, which is one of the biggest informal settlements in West Africa. The people in Monrovia, in the agency called Community-Based Initiative under the lead of Dr. Masoka Fala, they wanted to know how to do research, how to conduct research, how to analyze data. So I held a series of 3 workshops on how to do coding and thematic analysis of the transcripts that they had gathered, and then how to do analysis and write-up, and that has been very successful. Was fortunate to go to sort of the WHO sort of hearings in or meetings in Monrovia. On the bottom, 3 pictures. These are the interviews that were done in informal settlements. Interviews organized by Joseph McCarthy in Freetown, in the informal settlements there, and we talked to urban planners and so forth. Saba, next slide, please. So then we took the work to Kinshasa, to DRC, and many of the responders were sort of centered at first in Kinshasa before they went to the Eastern DRC. So we held 2 workshops there. We were very fortunate to interview Professor Muyambe, who people recognize as one of the co-discoverers of the Ebola virus, who took over the response. Our first sort of connection in the DRC was the Minister of Health, but then he had to leave the position, so we kind of had lost our contact there, but we proceeded with what we have. We went to, Masoka went to Goma and established connections there, and so we're still developing those leads. Saba, next slide, please. Yeah, so this is just one of the workshops that we had with the Minister of Health, as well as the Minister of Public Health, and with the various responders from the different regions to train them on the community-based response. So next slide, please. So these were presented at various conferences. I realize in Africa, one of the things that is kind of understood after you give a workshop or something, that a certificate is given. So as I said, we had done workshops on how to train the people in community-based initiative agency how to do research, and so we produced certificates. A unique experience for me, the project was covered nationally by the CBC on a news program called The National. So on the bottom left is an interview done in my messy office, but I said this is a different experience for me. I'm not used to this sort of media work. We're already started on the manuscript preparations. These 4 have already been sent out for review, okay, and more are in the pipeline. And there is a website for the project if anyone is interested. And I think that takes me to the end. Oh, upcoming updates, sorry, one more. So we've had to pivot, like many of you, to deal with the COVID response. And since we had some funds left, we're looking now at the question of how the sort of social infrastructure that was established during the Ebola response, how the people were mobilized, how the resources were mobilized, how the support was established, how that experience during the Ebola crisis carries over to the COVID crisis. Okay, so in particular, we're looking at how residents in informal settlements in Freetown and Monrovia adhere to the protocols that have been developed to prevent the spread of COVID-19, how educational initiatives based on information and communication technologies, particularly the social media, because for the young generation, they're completely rely on the social media to communicate. So we're looking at the role of the social media on how it influences the response to COVID-19. And we're undergoing a pilot study, one in a rural and urban community in Liberia. And now I think we're at the end. Let's see.
Now, Dr. Nouvet, thank you, Dr. Arisali. Okay.
Hi, thank you very much. So as Jude mentioned at the beginning, I'm based at Western University in London, Ontario, Canada. And I'll just briefly give you an oversight of my IDRC project, which is in collaboration with colleagues Dr. Muyembe in DRC and Dr. Mandi Kader in Guinea as co-PIs. So it's in 2014 with the Ebola outbreak in West Africa that I began to focus the bulk of my research on public health emergencies. And at that point, as many of you might already know, the World Health Organization, as well as Médecins Sans Frontières, Red Cross, Partners in Health, started to hire and advertise for social and cultural anthropologists. And it felt like the first time that anthropologists were being brought in. So it's really been a shift, and I'm really glad that this webinar is happening this series is happening, because we are seeing a really strong recognition for the social sciences. I didn't go to the West Africa outbreak as I had small kids, but shortly after started doing research there on actually research. So in particular, my interest is in moral experiences of research during public health emergencies. And this immersion in the world of research during and immediately after the Ebola infectious disease outbreak of 2014-16 connected me to the project that I have with IDRC, which is looking at how to strengthen the ethical conduct of research in Ebola affected countries, specifically Guinea and Democratic Republic of Congo. And at the core of this project is the challenge of how do you support voluntary and informed consent in high fear, high stress, high rumor contexts of public health emergencies? And how can those approached to participate in a treatment trial or approached in their neighborhoods after a public health emergency or during a public health emergency for vaccines, so very much an issue that we're seeing now, vaccine trials, be supported in their rights to understand and make informed decisions about whether or not they want to participate in research. Next slide, please. So it was Ebola survivors and participants in clinical research during the West Africa Ebola outbreak in Guinea who identified a serious gap in current strategies to support the rights of specifically limited literacy adults approach to participate in infectious disease treatment or vaccine studies. So I was doing some of the research on moral experiences of studies and thinking about next steps. Somebody explained that when they had been invited to participate in research, they were scared. It was in the midst of panic. They felt like they might die. They were unsure what they'd heard. They were unsure what to expect from the research or what questions they could ask or should ask. So what if people like himself, this Ebola survivor, suggested could be better prepared to navigate invitations to participate in research? And that's how we started this IDRC project of a toolbox developed with and for limited literacy adults. So we can go to the next slide. So this is the toolbox, which is not yet finalized, but will be available open access in March 2021. has been developed with a team composed of community engagement officers, Ebola survivors, as well as researchers in Guinea, in collaboration and dialogue with ethicists and social scientists like myself in Canada, and with an international steering committee of individuals involved in research ethics governance. So there's been a very iterative dialogic process to kind of figuring out what would you need to know if you had never heard about research, if you weren't even sure, about what, if a consent form is coming to you for the first time, how do you support people to better navigate those situations? So what's in the toolbox ultimately are 6 short films ranging in length from 6 to, the longest one is on the consent form, it's over 20 minutes. A poster, a flip book, and a facilitator's guide. The films have been produced by l'École des Beaux-Arts from Guinea, so you're seeing some stills from those here. And they touch on key concerns or points in need of clarification, such as the distinction between healthcare and research, such as, who's involved in decision-making, or, how does a trial, medication, or intervention make it to community? What are all the steps that have to happen before, there can even be a trial offered in a place like Guinea? And the facilitator guide includes discussion starters and some key takeaways for individuals who want to work with the toolbox so that they can kind of try to ensure that participants retain or discuss some key points when viewing it. Next slide. So the upcoming activities in the next weeks, we are finally now that there was a pause, piloting the toolbox, followed by debriefing interviews with workshop participants at 3 distinct sites in Guinea with different exposure to infectious disease research. And then we'll be translating the toolbox not only into English, but it is being translated, the tools are being translated into Susu, Malenke, and Swahili. And they're all going to be open access and hard copies available as well for low connectivity context. So please contact our team through my email if you are interested in learning more. Thanks.
Thank you, Dr. Duvet. It is my turn to present our project. Our project is a collaboration between researchers from 5 universities from 3 countries, Canada, Democratic Republic of the Congo, and France. It addresses the mental health consequences of the Ebola virus disease, but also the COVID-19 pandemic. Although our field studies have changed some of our operational objectives, this project has 3 main objectives. The first one aimed to document the prevalence, risk, and protective factors associated with mental health problems among populations affected by the Ebola virus disease in the Democratic Republic of the Congo. Second, to develop an evidence-based prevention kit. And finally, to develop a culturally sensitive and evidence-based psychosocial intervention guide. We conducted a mixed methods research. First, we conducted a 2-wave longitudinal survey from March 2019, 7 months after the declaration of the end of the 9th EVD outbreak in the 3 health zones affected by the 9th outbreak. The study was conducted with a representative sample of 1,614 participants, adult participants, 50% of women, and a group of more than 1,200 children and adolescents. Second, we also conducted a qualitative study with 60 interviews with survivors, orphans, and healthcare workers. Because the circumstances, we also conducted a multinational cross-sectional study on COVID-19 in Haiti, Togo, Rwanda, and DR Congo. but also a cross-sectional study among more than 1,300 survivors, orphans, and healthcare workers in the east of the Democratic Republic of the Congo. About the results, we already published many articles from our different databases, but we did not explore yet the longitudinal data. I want to particularly note the publication of 2 systematic reviews, one on the prevalence of mental health problems in populations affected by the Ebola virus disease, and another on mental health programs among populations affected by Ebola virus disease, which is already very cited. I also want to note the publication in April 2020, in the middle of the first wave of the ongoing pandemic, of the bilingual psychosocial intervention guide, intervening in the context of infectious disease outbreaks. It was printed in 300 copies by UNICEF and distributed for free for psychologists and other mental health professionals in DR Congo, but also it was downloaded more than 20,000 times on different websites. We have also organized training sessions for mental health professionals in the Democratic Republic of the Congo with Canadian colleagues. In addition to the upcoming publications, we will be organizing a series of knowledge transfer activities over the next 6 months, including this conference series, which is a collaboration between the 4 IDRC funded projects. Now I think we can go to our special guest. Let me introduce them. First, let me just tell you, each intervention will have a duration of 15 minutes. And at the end of the 3-part presentations, there will be a Q&A period. First, we will have Dr. Joseph McCarthy. He is the Executive Director of the Sierra Leone Urban Research Center in Freetown. He holds a PhD in urban planning and management from Newcastle University, UK. He's an innovative urban planner and a well-established scholar in urban development with backgrounds in urban management, climate change, adaptation, and disaster risk and resilience, with specific expertise on urban Sierra Leone. He also lectures in the Institute of Geography and Development Studies at Njala University in Sierra Leone. Please welcome Dr. McCarthy. Dr. McCarthy, you can share your screen. Dr. McCarthy, are you on mute? Because we can't hear you.
Wow.
Now it's okay.
Hello?
Yeah, we can hear you now.
Okay, can you see my screen, please?
Yes.
Okay, thank you very much. Hello, everyone. I am doing a presentation on Sierra Leone, basically attempting to describe the COVID situation in Sierra Leone as it relates to the topic. And most of what I'm going to discuss is based on the research we've been doing jointly with York University, but also with the IDS in the UK and LSTM. Okay, essentially the COVID situation in Africa started with the first case in Egypt, especially in February 14, 2020 this year. But most of the countries in Africa actually started experiencing the disease in March. And as at 18th April 2020, there were already 19,895 confirmed cases from 52 countries, with a mortality rate of 5.1%. And so this particular situation gave cause to particular kinds of theories that's been floated around, especially in terms of what is likely to be the expected, that Africa was going to experience much of the consequences of the COVID-19 disease. And so therefore, this particular presentation is going to really present what actually was the case in Sierra Leone. But then one of the key reasons why Africa was expected to be the key disaster point was because it was seen mostly as a continent that was a lot different from all the other continents, especially so because it was seen to be ill-prepared to contain the disease. So basically, one of the key logics for that particular kind of conception was because of its weak health system, because for many countries, it was an area that was underfunded. And also because of this, there were a lot of problems, especially in terms of access to medical supplies. And also most of the staff were not considered to have the required competencies for diagnostic and also intensive care to run the intensive care units. So it was generally believed that the testing capacity for COVID was generally lacking in Africa, and that most of these countries have been already struggling with their economies even before COVID-19. So they didn't actually. There was also the conception that the cities are already experiencing informal settlement situations, and so therefore these were going to be the seats for the spread of the disease. And already it was also argued that for many people in these countries, they were already struggling with other forms of diseases, which this COVID-19 was going to exacerbate. In the case of Sierra Leone, this particular table presents the way in which the COVID situation fared across the country from March 1st, when we had the first case, to 15th November, which I consider to be the cutoff point for this particular presentation. And as you can see, the total cases have continuously grown. But when you look at the second column in the table, it will show that, yes, the cases have been growing over time, but as at May 30th, rather, that was the point when it started to drop. So the progression shows that, yes, it rose up to May 30th, but then it started to drop until on the 30th of August, when it rose again, but started having falling continuously over time. Of course, the death total increased, but we have only had 74 deaths so far. And the recovery rate is also very high. If you see this other table, it shows the weekly cases over time. And it shows that much of the experiences were within the period week 21, 22, week 21 and 22, especially corresponding to the May period I just talked about. There was a drop and a rise, but then it has been falling throughout this particular time. And this other graph also shows, the blue line shows the total cases, which has been increasing. The yellow line shows the total recovery. But then in terms of the progression, especially the brown line, shows that yes, there was an increase, but over time it had flattened and it has been decreasing ever since. So what does this mean actually for the COVID response situation in Africa? Basically, we did not, the different countries in Africa did not adopt a one-size-fits-all response. There were different approaches, and so therefore, each country had a particular pattern or a particular response strategy to adopt. And most of these strategies shifted from a strict enforcement kind of response to a light enforcement kind of response. And of course, countries like South Africa more or less preferred the rigid response when it initially started, but countries like Tanzania have usually preferred the light enforcement measures. In Sierra Leone, we started from strict, but we progressively moved towards a light form of enforcement measure. The initial responses before the pandemic was to close the airport and all border crossing points, to close all educational institutions and mosques, but also to ensure that nobody travels from where you are. Inter-district travels were restricted so that nobody moves from where you are and take it to another part of the country. But then one thing that actually stood out was that Sierra Leone had experienced Ebola before, and so there were a lot of lessons that we actually learned from that we put in this COVID response. And also there were also institutions from the Ebola response that were put at the disposal of the COVID response. Basically, during the pandemic, some of the COVID response strategy was to promote hygiene measures, especially in terms of distancing, because these are helpful at the time of social and economic recovery. So one of the things I use this hard but progressively move towards the soft was to cushion some of these social implications on the people. The other actions that were taken by the government was to resurrect the Emergency Operations Center. This center was very vital in the fight against the COVID. It is a center that is a little removed from the health sector, but also from the defense, but one that is positioned such that you have different sectors coming to work to respond to the pandemic. They also established what we refer to as the Interministerial Committee, because the COVID was seen as one that cuts across different sectors. So this particular committee was set up to ensure that the different pillars that corresponded to the disease were actually addressed. The government also worked out to develop a diagnostic capacity of 3 different health laboratory facilities that were put at the disposal of the disease, but to also ensure that risk communication trainings were also promoted. And also in terms of supplies, especially in terms of health materials, especially in strategic positions, were also promoted. The government also decided to allocate more funds to the fight against the Ebola, but to also promote local resource mobilization within the country and within the remits of other structures that exist. For instance, religious leaders are highly recognized, highly respected in their communities and across Sierra Leone, and so they were brought into the fight. Traditional leaders who are highly respected as well were brought into the response. We also have recognized political leaders at different levels who were brought in because these generally have a voice in the communities and people can listen to them. But beyond all, the community residents and their group were also brought in because then their capacity needed to be promoted, but also not only to adhere to the protocols that were developed to respond to the disease, but also to ensure that they become an active part of the response, because these are the people who normally interact with each other, and they generally know their problems, their situations, and working with them generally will ensure that the messages do not only get down, but they take the necessary precautionary measures. The efforts of the government was supported by the World Bank at some stage, by the World Bank providing a grant, especially to help to cushion some of the financial gaps, but also the social safety net issues that I spoke about initially. So this particular graph shows the response situation, the COVID situation. The red line shows the level of deaths, which was very high when it started in March ending, 31 March, and the highest point was in May, but this progressively has been reducing. If you look at the blue, also it shows the number of cases which has been rising, but it's flattening up and started to drop. And we also have the recoveries which have also been increasing, but also decreasing as the cases started to drop. So then the question is, was really the epidemic one that was expected to affect Africa in a form of creating a form of disaster situation? To me, I think some of these ideas that were floated, especially in terms of this pandemic not becoming a disaster, especially in the forms of ideas that were floated in terms of COVID not being transmitted just simply because Africa has a warm climate, or just because Africa has more young population, or possibly because much of the tests were limited, and so therefore we are not providing the right kind of picture. I think those were really not the kinds of issues that made the disaster not to occur. What actually made the disaster not to occur was the way in which the disaster was managed in some of these countries, the kinds of control systems that were applied. I think this speaks volume rather than just assuming vaguely like what has been traded over the period. I thank you very much for listening.
Thank you, Dr. McCarthy. Really thank you. It was rich, passionate, and I'm sorry. I was speaking and I said thank you, Dr. McCarthy, for that rich and passionate presentation. And I have the same question that you have at the end for you. And I really appreciate your presentation. Now, let me introduce Dr. Patrick Daly. So you can stop sharing your screen, Dr. McCarthy. Let me introduce Dr. Patrick Daly, the face of the management of the pandemic in Haiti, Director of the Public Health Department at the Ministry of Public Health and Population. He is also the head of the scientific committee during the COVID-19 pandemic. He's at the front line and knows the data better than anyone else. As a reminder, in the Americas, Haiti is the country with the fewest cases and especially the fewest deaths. Yet it is the most fragile country with the health system considered the weakest in the Americas. But I'm curious, and I think all people are curious to know how they do it, how they manage that pandemic. Welcome, Dr. Daly. Bienvenue, Dr. Daly, et vous avez la parole. Vous êtes encore sur mute, Dr. Daly. Oh, parfait maintenant. Allez-y.
Thank you, Jean-Marie, for hosting me and at this forum. Hello, everybody. I'm glad to present you, to be with you this morning. That is the plan of my presentation. My goal is to describe the situation of the COVID-19 epidemic in Haiti, our approach strategy to fight it, and identify the possible factors that would influence the behavior of the epidemic in Haiti. First, we have to note that Haiti is a Western region country with a population about estimate about 12,700 people. We have a tropical climate with 27,800 square kilometers. When we hear about the epidemic in China, we know that we have a weak health system. We activate early our surveillance system in January 2020. And then we detect our first cases 3 months after, March 2020. And then from March to November, we already detect 9,188 confirmed cases. For again this epidemic, we activate our plan, our national plan, derived from existing avian flu plan and the ongoing flu surveillance system, influenza tracking, based on domestic experience in epidemic surveillance, cholera, and malaria. Our objective was avoid introduction if possible, limit the spread, reduce impact, inform the population, and train health professionals. For that, we reshape and strengthening alert and response system, a community-based approach in cases tracking. We use home quarantine as much as possible and isolation also for the suspected cases. We use health formation focused specially on health information, and we work together with the leader, local and international partners for, again, the epidemic. Guiding principle for IT response, we have three principal guidance, like intra and intersectorial coordination of the response. We follow the evolution of the situation by the national committee, collaborate with regional and sub-regional health authority in the exchange of information on the spread of the epidemic and carry out joint infection prevention and control action. Reinforcement of diagnostics capacities by the laboratory and protection of personnel. More important, we establish a network for active case finding and contact tracing at the community level to ensure early detection of cases and rapid interruption of local transmission. Disseminate weekly data on mobility and mortality related to SARS-CoV-2 coronavirus. We also ensure permanent availability of protection and disinfection equipment, carry out mass communication campaign. We apply support measures and strict application of risk management standard from care and diagnostic activities, ensure strict application of hygiene and rules. The key addressing COVID-19 in Haiti, weekly interministerial calls. We are working closely with all 10 region leaders of the country to ensure a comprehensive coordinate response to COVID. Scientific Committee of SARS-CoV to provide advice on coordination, public health policy, and technical content related to the COVID-19 outbreak. Realization of the situation room at the direction of epidemiology laboratory and research weekly, and feedback to the high-level system in order to better monitor the response activity of COVID. Deadly reporting of COVID-19 through the situation report. Establishment of a multi-sectorial committee composed of representatives of the state, the private sector, and the international community to ensure better coordination of COVID-19 pandemic. Taking action on COVID, like you can see, with strengthening surveillance and respiratory infection, the surveillance and parent of entry, like you can see in the photo. Deadly epidemiological parent of acute respiratory infection surveillance, establishment of quarantine and care space, capacity of the national laboratory, health laboratory to, confirm COVID, town hall meeting to determine evaluate implication of the response to COVID, and mass education campaign of the population by community health workers and using billboard, poster, telephone, radio, television, and social network, and be able to be held and measure of barrier. Establishment of sampling site in all regions to detect cases. We use this strategy for the contact cases, quarantine landscape, institutional and home quarantine, isolation, quarantine, home isolation. For all arriving passenger does not displaying any symptom must be quarantined. All arriving passengers with symptoms must be placed in institutional quarantine or home quarantine. All contact must be institutional or home quarantine. Duration of quarantine is 14 days. All detected cases must be placed in institutional or home isolation. People placed in quarantine have received a sheet indicating the measure to be taken to protect themselves and others. Regular monitoring was carried out at least 3 times during the quarantine period. It is a current situation of the COVID in Haiti. Like you can see in red, we have more than 140 cases in this region. Until now, we always detect 992 cases confirmed for 232 deaths was reported. I have to say the highest proportion of cases is between 30 to 39 years. It's about 20.1%. This is the evolution of the cases by March to date. Like you can see, we have more cases at the end of May, at the beginning of June. For now, we have about 8 cases by day. This is the cases and deaths we capped in our system by week from March to date. Like you can see, the evolution of the situation in the country. That is a resume of the mortality, morbidity, and fertility rate in the country by region. The region we have the mortality in the west, north, and grandest is in this region. For the fertility rate, the more important region is grandest also and Artibonite. We have a mid mortality rate about 0.08%, very, very low. That is very important to show you about our population by age group. Like you can observe here, more than 85% of our population is between 0 to 49 old. Many cases we have confirmed is between the young population. I think that is very important to understand that. For our plan, we also habilitated 626 care beds. But I have to inform you, we never use our all capacity for the hospitalization. I have to report also some issues like the epidemic in Bolivar in our population, a self-medication, a traditional treatment use and belief lead to modern treatment refusal, insufficient research work on virus and epidemic, no mass detection. And then the question is, in fact, the anticipated disaster didn't happen, but why? That is the question. We can say it's a little intriguing that patients that are more protected against moderate or severe manifestation of COVID are those from 10 to 14 years old. And then the risk increase with age, also previous common cold coronavirus CCC, can confer a level of protection against COVID-19 with phenomenon of cross-reactivity. as the age distribution of CC infection is not well established. It could be interesting to conduct studies on CCC in Haiti to have an idea about the age group distribution. We think that younger than 10 did not have the CCC, nor did they develop immunity. Those were as susceptible as adults. However, children aged between 10 and 14 were exposed to coronavirus and developed immunity that protect them from severe and moderate manifestation. Perhaps this immunity diminish or disappear over time, thus explaining the increasing incidence beyond the age of 15. In Haiti, I have to say most of the patients, 71.1% fall in the 15 to 49 age group, and only 9.5% age 65 or older. This may explain the lower overall mortality in Haiti compared to the prevailing rate elsewhere. Nevertheless, it is also interesting to see that the proportion of those over 65 years old, the population pyramid in Haiti is about 5%. So there is overrepresentation in this age group. A large sample study, 500,000 COVID-19 patients, revealed that age has a negative impact on case fatality rate with out of age of 15. Last word, what were the protective factors? We think pre-existing efficacy of surveillance system, early activated. Demographic pattern, young population is very important. Social behavior, outside living, self-medication, traditional treatment, we have to investigate them. Human status, use the infection, we have to investigate also. Geographic, sunny and warm winter, other on suggest one. I can say we did research need for answer those questions. We have to maintain our vigilance and care second wave, strengthen partnership, and look for a cooperation for operational research effort. Thank you very much to support my English. Thank you.
Thank you, Dr. Deli. Now we are going to welcome Dr. Annie Wilkinson. In the end of March, I wrote an article published in Travel Medicine and Infectious Disease with the title, The Vulnerability of Low and Middle Income Countries Facing the COVID-19 Pandemic. And I took Haiti as an example of the vulnerability of low and middle income countries. And I'm really happy to have that presentation from Dr. Deli. Now, let me introduce Dr. Annie Wilkinson. She's an anthropologist and health systems researcher. Dr. Wilkinson conducts interdisciplinary and applied research on health in low and middle income countries, and has expertise in zoonotic disease, epidemic preparedness and control, drug resistance, and urban health. She will give us a global view on the issue of the day. Thank you, Dr. Wilkinson.
Hi, and thank you. Thank you for inviting me. I'm just going to share my screen. Oh, there you go. Can you see that?
Yes.
Great. Okay. Yeah, so my name is Annie Wilkinson. I'm a researcher at the Institute of Development Studies in the UK. I yeah, I'm not going to talk. I do research on epidemics. I do research on urban health, actually, with Joseph, who was presenting earlier. But I'm not going to really talk about that today. I'm going to talk about, yeah, I was asked to provide a kind of an overview of kind of global spread, and then to focus specifically on the impact and what's been happening in Africa and how and why that seems to have kind of confounded expectations. Let me, maybe I need to, sorry, I'm trying to move the slide on. Oh, there you go. Okay, so quickly, globally, oh dear, I need to move my, sorry, I just need to, I'm covering up the slide with the speaker, with the thing, there you go. Okay, yeah, so these are some really nice slides that I got this morning, actually, off the European Centre for Disease Control, that shows the distribution of COVID cases worldwide. And as you can see, there is, it's been steadily rising, although this is probably also tracking expanded testing capacity in many places. But the dark blue is Europe, the light green is Asia, the light blue is America, so that includes Latin America and North America. And then the tiny little bits of green at the top, which you might not even be able to see, is Africa. So globally, the proportion of cases is that the Africa accounts that come from Africa is really, really small. And then this is a similar graph, but of deaths. Colors are all the same, so lots of death in Europe, in Asia and the Americas, but again, really, really small proportion of deaths coming from the African region. And again, my thing's in the way, sorry. So this really contrasts with some of the predictions that previous speakers have kind of also been discussing, whether it's in relation to Sierra Leone or Haiti. There were expectations and fears that the deaths in African, sorry, obviously Haiti's not Africa, but there were real fears in lower middle income countries, but then in Africa in particular, that there would be high numbers of deaths. And so the WHO in May had a model that said there'd be up to 190,000 deaths and between 29 and 44 million cases could be expected in the first year of the outbreak in the African region. And those figures, I think, were already slightly revised down from some of the initial kind of fears and models. And this is where now the first cases in Africa were, as Joseph said, in February in Egypt. So we're 9 months in. And this prediction clearly has not come to pass. The heightened fears, I'll just kind of quickly characterize that I think they mostly revolved around issues about the limited healthcare infrastructure. So there was a lot of discussion, if you can remember back then, earlier in the year, about the number of ventilators that there were in African countries, and how basically weaker and underinvested health systems are in African settings in general. Lots of generalizations, I'm afraid, as I'm talking about the African content in general. Poverty as well, that there was just the expectation that this was going to make Africa particularly vulnerable, and also really unable to kind of sustain the control measures. So some countries that were able to kind of inject a lot of support to enable the kind of social distancing control measures were that kind of support was not going to be possible. That there was also immunocompromised populations, so there were lots of fears around kind of malnourished populations or people with HIV and TB. There were concerns about intergenerational mixing. There was also concerns about crowding especially in cities, and it is true that lots of kind of African capital cities are pretty crowded. And also about the lack of sanitation. And I was one of these people that was fearful about what could come to pass in Africa. So this isn't me kind of saying that that we knew, that some of us knew better all along. But those I think were the kind of the basis of the fears. And And here is actually what does seem to have happened in Africa. So I already showed you globally what a small proportion of cases and deaths Africa accounts for. And here are the actual numbers. So as of the 17th, yeah, again today, the African CDC has got recorded under 2 million cases, just under 50,000 deaths. And many places in Africa not particularly affected. There's in kind of northern and southern Africa there have been cases, and I think so it's definitely not true that everywhere has been unaffected. I'm just gonna now, yeah, so I was asked to kind of talk about some theories as to, or some potential reasons as to why this is, and my initial instinct was I don't know, and I don't think that anyone actually knows for sure. So this table here is me trying to kind of put together what I have seen as to some explanations, to summarize some of the explanations that I have seen that have different levels of evidence, I think, backing them up. So the first one is a kind of things around data and the indicators. And so there is concern about there being under testing in lots of African countries. And it is also true. I think most people agree that there is under testing. Testing capacity isn't particularly strong. I think there's about 10 countries contribute to 80% of the tests that get reported. So there's some places that report quite well and other places that don't. But there's also I think people also think that if there were lots of cases mounting up, an unchecked transmission in the community that was causing disease and death, that you would begin to see hospitals being saturated and you begin to see lots of deaths. And that's not happening on a grand scale. So I think there's general consensus that yes, there's under testing, but perhaps it's not to the extent that this these low case numbers are a complete artifact. Some interesting data that I discovered, and I can't get to the bottom of it, but there was a WHO review saying that 80% of cases in Africa were asymptomatic, compared to something more like 40% in the US or Europe, which were asymptomatic. So possibly a suggestion that there is milder disease milder disease in African settings. So then the question is, well, why? There's lots of discussion about the kind of what I've called here demographic. Just to finish on the seroprevalence. The problem with this kind of these questions around data and testing is that we don't have good seroprevalence data across African settings. There have been some surveys and they've found something between 3 and 12% of kind of evidence of past infection in different populations. So, but it's very patchy. So we're kind of still guessing on that. Another very popular explanation is to do with the age structure in Africa. So Africa's population is the lowest, on average, kind of the youngest in the world. Only 4% of the African population is older than 65, as compared to 37% in Europe. So lower numbers of people that are kind of epidemiologically at risk, possibly why and where we tend to see some of the more severe cases. Which links again to the recognition and the kind of testing. There's also lower rates of some of the critical comorbidities, so diabetes, hypertension, heart disease. Lots of these things that are causing severe disease in other countries are just lower. They're not non-existent, but they are lower. There's a host of issues around transmission and conditions in African settings that may be more or less favorable to transmission. Population density is one that has had some attention, and then also levels of urbanization. I've suggested at the bottom here, there's a paper called "Why is the number of COVID-19 cases lower than expected in sub-Saharan Africa?" that does some basically kind of regression analysis on different demographic and geographic indicators, and actually kind of tests out some of the theories that are in this table here. And the ones that they found to actually have to correlate significantly with levels of with COVID cases was age structure, and then it was also population density and levels of urbanization. So even though there were, as I mentioned earlier on, concerns about crowding in some African settings, like on taken as a whole, the continent has a lower population density than I think anywhere in the world, except apparently for North America, and also has some of the lowest urbanization rates. So urbanization is a really, really big trend in Africa, and Joseph McCarthy that spoke earlier will be able to tell you much more about that. But levels are still currently at the moment lower than elsewhere in the world, lower than many other places in the world. Some other kind of suggestions about people traveling less or spending less time outdoors. I think those things are a bit hard to verify. Then there's these kind of there's a collection of theories around possible immunity in African populations. So cross reactivity, cross immunity from other coronaviruses, or even just other hygiene, other infections. So this is kind of a version of the hygiene hypothesis. So there's maybe some of the places that have higher infectious disease, other forms of infectious diseases, people have kind of built up some more immunity, and possibly some genetic factors. These are all, as I've said, hypotheses with varying levels of evidence behind them. Climate, others have mentioned, both the previous speakers have mentioned climate. There's things about how stable a virus is at different temperatures, and COVID does seem to be, at least in some places, it does seem to have a seasonal transmission, but it's definitely not true that it doesn't spread in hot environments. So the other one that is, I think, really important, and Joseph highlighted this, is about response. So lots of people saying, well, actually, lots of African countries took early and effective action. They went into lockdown early, and they, reduced travel, stopped travel early. And I can testify for this. I was in Sierra Leone in January and February doing research on epidemic preparedness, and immediately, there were hand washing stations had come out. There was daily briefings coming from the Emergency Operations Center, which Joseph mentioned, a really high level of kind of a quick and effective kind of response at that country level, possibly linked to the Ebola experience from the Ebola, well, I think very much linked to the experience from the Ebola outbreak. And I flew back to the UK in early January, and there was just basically very little happening. so a real contrast in terms of governmental response, and I think that's true in many African settings. There was this early action. There's also been really significant regional cooperation and coordination. I think where, for example, again in Europe, we're not managing to kind of see that, and particularly from the UK perspective, but there hasn't been a lot of cooperation, whereas I think with the African CDC and the African Union, there has been a lot of kind of work at the African regional level to coordinate the response. And so particularly around, control measures, but also things like access to vaccines, also things like pooling, in recognition of diagnostic limitations on diagnostic capacity, there's been shared pooling of diagnostics. So some really important innovations there. And I kind of touched on this before as well, but also the experience of other outbreaks. I touched on Sierra Leone's Ebola experience, but there's also, Ebola experience in places like DRC and all the surrounding countries, but also, HIV or measles, places where there have been kind of and polio efforts to kind of stamp out infectious diseases that may have stood some of these countries in better stead. Possibly, I've just put this in, possibly more localization of the response, recognition of the importance of kind of community involvement, of community engagement, all of these things that, again, others have spoken about before me. that has been, I think, quite absent from some of the some of the kind of other settings. We've, again, in the UK, big debates and calls for increased localization, which have been really slow to come and really resisted. There's some people have talked about timing and said that lower numbers at the beginning or a slower rise at the beginning provided an opportunity to learn from other countries. I think, you know, in reality, it's going to be in different places. There's probably no single answer. It's going to be a combination of many of these things, and that combination will likely be different in different places. The other point is that actually some people at so the head of WHO Africa have started to say, well, also maybe it's just a different epidemic because of probably all these factors, but actually we will look at a different kind of epidemic in Africa. So there's not going to be this kind of exponential curve that we're seeing in other places, but it might be something that is more prolonged when you kind of get kind of transmission hotspots, and that it could kind of go on longer and potentially bubble away as a kind of an endemic disease. So the question that we've all been asked about, you know, the expected disaster that didn't happen, it's certainly true that there have been unexpectedly low numbers of cases in Africa. But I just want to raise an issue of like whether this is a disaster avoided, or was it not the disaster we were expecting? Because if you begin to look more broadly at some of the secondary health impacts and some of the indirect consequences, which you know, too many really to list, but there's economic impacts. We have seen violence being used to enforce the control measures. There has been in some places kind of political repression. None of these are unique to Africa as well. And there are food security issues along with a host of other concerns. So yeah, just to slightly challenge the idea that there hasn't been a disaster, because if you take some of those things into account, then things begin to look quite different. And I've just got a few little slides, about that. So on the secondary health impacts, surveys done amongst African Union members have found that, I mean, there's increasingly data on this stuff, so it's hard to choose which, but it doesn't paint a good picture. So 44% of respondents said who said they had been in need of care, delayed or skipped their healthcare visit. 47% reported difficulty accessing medication. Some of this is that health services were closed, or they were assumed to be closed, or people were simply fearful of going to them. There's been routine immunization coverage. There's been substantial drops there. So the DTP3 immunization, which apparently is an indicator of immunization coverage in general, that does these three diseases together, has dropped, and apparently significantly dropped for the first time in 28 years. Measles vaccinations have been cancelled in many countries. And so there are real fears about future kind of morbidity for this potentially unvaccinated or undervaccinated generation. And I think, as Karen mentioned in the very beginning, some of these secondary health impacts are quite hard to measure. We did see them with Ebola in West Africa. We see them, to be honest, in most epidemics. It is often hard to measure them. But relatively, I think if you look, WHO predictions of 190,000 COVID deaths were always going to be a fraction of the 2.7 million preventable child deaths that occur in Africa. That occurred in 2018. I've managed to miss the date. Oh no, I've got the date. 2.7 million mostly preventable child deaths, or the 390,000 malaria deaths that occurred in 2018. And if there are any interruptions to the kind of essential services that are already struggling to meet those health challenges, then, you know, we can start to think that actually secondary impacts are likely to exceed COVID morbidity and mortality. Then finally, there's also the economic impact. So these are some World Bank figures on the numbers of people that they're predicting to be put into extreme poverty. So there's different measures of extreme poverty here, either $1.9 a day or $3.2 a day or $5.5 a day, all pretty small already. But so despite the really, really tiny numbers of cases that in the African region, the purple, so the top parts of these bar charts is what is for sub-Saharan Africa. And you can see that actually despite that small caseload, there's predicted to be a kind of a disproportionate economic impact in sub-Saharan Africa. So the regions that they think are going to be really poorly affected economically by COVID-19 are South Asia, which has been hit quite hard, but also sub-Saharan Africa, which is quite sobering. And then luckily I work in Sierra Leone quite a lot, and I'm glad Joseph was able to talk about the urban setting, and thankfully I decided not to talk too much about that today. But these are some pictures, these are old pictures actually, but we have a project which is also looking at pandemic preparedness at different levels in Sierra Leone and in Uganda, and particularly about kind of community experiences and community knowledge, and one of the things that people are saying to us there is that the harvest, the agricultural cycles have been really disrupted. So in February, March and April, which is when Sierra Leone did, even though I think, as Joseph said, they've been kind of relaxing some of the control measures, but there was kind of intermittent lockdowns, and people, at least in the rural areas that we were working in, were told not to even go to their farms, and there were some restrictions on that at exactly the point where planting, where identifying your farm, burning and clearing the land, and planting rice for the year to come. That's all the period the time that happens in, and people were not able to do that to the extent that they normally are. And then the other part, this picture in the top right, is of a work party. So large groups of people will go and kind of work on the different farms, and because of the kind of potential for contacts there, people were kind of discouraged from doing that. There has been a big, they are saying there's an issue around food security and the harvests for this year. And this is the end. I wanted to just kind of, so I've kind of talked about how there were some predictions or some expectations which have turned out not to be true. To give it a little bit of a social science spin, is to just think about what are some of the narratives that we have about pandemics and about the African continent that have informed some of them, and so informed some of these incorrect assumptions. So Dr. Kenga Song, the director of the African CDC, said very explicitly, the projections were embedded in a shallow understanding of the continent and a rush to make up headlines. I don't think the assumptions were solid. I think they were based on stereotypes. Modeling is only as good as the assumption put into it. And I think that, on reflection, I think part of the predicted disasters in African settings were often about powerful narratives about the African continent, that it was in some way kind of inevitably vulnerable. It was homogenous in its invulnerability, and that it was, dramatically more vulnerable than other parts of the world. And I think a lot of that was based on, concerns about very real and understandable in some way, concerns about material and infrastructure deprivations that were seen to be the root of the of Africa's vulnerability. But actually, COVID hasn't played out like that. Those infrastructure deprivation hasn't been a huge issue. We're seeing kind of high rates of spread in some of the richest countries in the world. And also, I think there was a kind of an idea about a deficit of kind of expertise in Africa. Like, institutions in the global north were very confident in their own pandemic response expertise and strategies, and that has not come out very well. And there's been, again, a lot of kind of commentary about needing to kind of learn from African settings. I think also there's narratives we've so Dr. Kengasong, I think, was picking up on things about assumptions about Africa, and I think those are really important. I also think that there are just assumptions about pandemics, that they are kind of universal. I mean, that's the pan in the word, is that it goes all over the place, but actually it doesn't mean that it's going to affect everywhere in the same way. It doesn't mean that it's going to be all encompassing everywhere. And I think often there hasn't been the sufficient enough distinction between diseases. And we tend to think in terms of the last disease, so whether it was Ebola or whether it was flu, or even SARS, although maybe that's more appropriate in this case, rather than something novel, which we don't understand, we can't predict, and that we need to really kind of understand how it works in different contexts and kind of calibrate that. Yeah, and so I just kind of put some questions here, and I wonder whether these powerful narratives that we tell ourselves, sometimes without even realizing, have kind of obscured in Africa, but elsewhere in the world, regional and local variation. They've driven one-size-fits-all approaches, which have in some places done avoidable harm. I mean, I know one of the explanations for success in Africa is about early and swift response, one of which is lockdown, but we can also see that lockdowns have done quite a lot of, have done harms, and perhaps they were primarily to protect the global north, or that's what the kind of the implications are, and that we have failed to appreciate social context, social dynamics, and local expertise, which, as social scientists, I think we're all well versed in understanding that those are important, but sadly, I think they don't often get the prominence that they need in epidemic response. And that's it. I hope I haven't gone over time.
Thank you, Dr. Wilkinson. I will let Saba lead the Q&A session. Saba?
Hi, everyone. Thank you for all of the wonderful insights during this conference. There are just a few questions. We don't have very much time, so I'll just ask a couple here. This is from Joseph for Dr. Patrick Deli, who had replied in the chat, but just for everyone else. In Haiti, what do you use for travelers arriving? Do you use symptoms or a PCR test? So Dr. Patrick Deli.
Laissez-moi traduire en français, puis Dr. Deli can answer in French too. Dr. Patrick Deli, la question c'est qu'utilisez-vous pour les voyageurs qui rentrent en Haïti en présence de symptômes ou du résultat d'une PCR? C'est-à-dire, si le résultat est positif, qu'est-ce que vous faites dans ce cas-ci? Qu'est-ce que vous utilisez? Dr. Deli.
Je n'avais pas trop bien saisi. Si le résultat est positif.
Si quelqu'un rentre en Haïti et que le résultat est positif ou la personne a des symptômes, qu'est-ce que vous faites?
Ah, OK. On fait deux choses. Dans le plan de réponse que nous avons, si la personne est positive, mais elle n'est pas symptomatique, on demande à cette personne-là d'observer l'isolement à domicile, si la personne est asymptomatique. C'est-à-dire, on demande à la personne si elle a les conditions de rester chez elle, d'observer et de rester en isolement. Et on fait un suivi, on lui donne un petit document qui lui informe sur les signes alarmants et au cas où il développe des signes qui peuvent mettre en péril sa vie pour pouvoir intervenir. Ça, c'est pour les gens qui sont asymptomatiques. Mais si la personne est symptomatique, on met cette personne-là dans un isolement institutionnel.
Okay, thank you. Saba, you can translate?
Yeah, so Dr. Deli has said that if somebody arrives in Haiti and they test positive for COVID, there are two sort of options. If they are positive with no symptoms, they're asymptomatic, they send them to self-isolate at home, and they give them a document that gives them further information for if the disease progresses or they have further symptoms. However, if they test positive and they also have symptoms, then they put them in institutional isolation. So that could be in a hospital or some sort of healthcare setting, I imagine. Okay.
Je dois ajouter qu'il y a un système de télémédecine qui existe, un groupe de gens qui appellent ces gens-là pour un suivi systématique et continu avec eux.
Okay.
Dépendamment si la personne est en isolement et à domicile ou bien hospitalier.
Okay, thank you, Dr. Deli. So he has also added that there is a telemedicine service that they're able to follow these patients who have tested positive to make sure that when they are self-isolating, their disease is not worsening and to keep tabs on them. Thank you for that. So second question is from Josephine, and this was written in French, but I'll translate it to English. In the predictions of why COVID-19 might not be a disaster, they talk about poverty, immunocompromised diseases such as HIV, malnutrition, tuberculosis, the inappropriate health system. How can we explain that this positively influences the non-propagation of COVID-19 in Africa? And she apologizes that the language might not allow her to capture the content of the presentations.
And the question is for Dr. Wilkinson.
Yes.
Yes. Dr. Wilkinson?
Hi. Was the question, why are they, I think what I was trying to say is those were the fears, but actually those are not things that have turned out to be true. So there have not been relationships between most of those factors I listed and the spread of COVID.
Okay. Okay, thank you, Dr. Wilkinson. And one last question again for Dr. Patrick Deli. Why is the CFR higher in artibenite and ground ants, I believe, in Haiti?
You can translate in French, Sabah?
Pourquoi le niveau de CFR est plus
élevé dans l'artibenite et la tendance? C'est pour Dr. Deli.
Merci pour la question. Et quand on a mis en place le plan de réponse à la COVID, il y a certains départements où on a eu des difficultés et pour faire appliquer ce plan le plus tôt possible. Et ça, c'est l'un des cas, par exemple, de la Grande-Anse, qui explique que quand on a eu les premiers cas au niveau de la Grande-Anse, le département n'était pas encore prêt pour faire face à ces cas-là. Ça, c'est une réponse. Ensuite, pour la tibonite, c'est le département qui a reçu les premiers cas. Les premiers cas qu'on a détectés dans le pays, c'était des personnes qui proviennent de l'étranger, mais c'était arrivé dans la tibonite. Et à ce moment-là, les gens n'étaient pas encore trop sensibilisés et il y avait une sorte de résistance. Les gens ne comprenaient pas ou bien n'acceptaient pas l'existence de la maladie. Et c'est des choses qui expliquent pourquoi on aurait que le taux est plus élevé dans ces régions-là.
Great, thank you, Dr. Deli. So you brought up 2 points. Basically, in the Grand Anse, the departments that were to be taking care of the pandemic and attending to it were not adequately prepared at the outset to meet the demand. And for the first cases in artibenite, they were actually the first to receive cases of COVID-19, and the public was not as sensitive to the cases, and there was a bit of resistance in accepting the fact that a pandemic was happening, so the response was a bit delayed. That's why the levels seem to be a bit higher, if I understood correctly. Great. So thank you all very much. I think I will let Jude say a final goodbye and wrap up the conference. If he's still there, I know.
Thank you for to all for being here. The next conference is on December 8th, and we will speak on access to care during the COVID-19, during pandemics, during outbreaks in general, but especially during the COVID-19 pandemic. I would like to thank Dr. Sharon from IDRC, Dr. Nouvet, Dr. Arisali, but Dr. Karen Grépin also. But a special thank you to our guest speakers, Dr. McCarthy, Dr. Wilkinson, and Dr. Daly. The conference will be on our YouTube channel and V-TRaC Lab, and you will be able to watch it and, or to share it. Thank you all for being here. It was a pleasure, and we hope you will be able to join us on December 8th. Thank you again.
Thank you, Jude. Thank you, Sabah. Bye, everyone.
Bye.
You.